Hello and welcome to the lecture on kidney disease. Today we are going to talk about acute kidney disease, chronic kidney disease, and all of the renal replacement therapies or dialysis. Here I've listed the objectives. In general, we're going to learn all the pathophysiology, clinical manifestations, diagnostic studies, and collaborative management for patients with renal disease, acute, chronic, and renal replacement therapy. Here is a diagram of a nephron. And the nephron is the working unit inside the kidney, as you know. And I want to trace what happens normally as we filter the blood through the 100 million nephrons in our kidney. Well, first the blood comes into the kidney through the renal artery, and then it enters into the nephron, into the glomerulus. You can see that on the right-hand side, or left-hand side, excuse me. And the blood enters into the glomerulus, and the glomerulus filters the blood, and it makes a filtrate. It filters out all of the fluids. It filters out toxins, it filters out electrolytes, good and bad, and it makes a filtrate. What it leaves inside the blood vessels themselves is the larger molecules, the white blood cells, red blood cells, things like that. So we make a filtrate, filter all the blood, and then we move into the proximal convoluted tubule. You can see it there with the blue and the yellow arrows. And in the proximal convoluted tubule, we start to reabsorb. We start to reabsorb things that we need, more fluid, all the electrolytes that we need to maintain inside of our blood. And it moves then down through the loop of Henle, that big loop down there. And again, we're pulling back more water and more electrolytes and things that the body needs through processes of active and passive transport. You can see it's described here. And then it moves into the distal convoluted tubule. Again, in the distal convoluted tubule, we are reabsorbing more water. Calcium and sodium are being reabsorbed in the distal convoluted tubule. In addition, the blood from the main body is secreting things like hydrogen is being secreted into the renal tubule. That's where a lot of drug toxins get secreted into the renal tubule. And then the blood moves into the collecting duct, where the job is to concentrate the urine there. This is where we are going to reabsorb sodium, water, bicarbonate, potassium is all reabsorbed there, and then it moves down through the collecting duct, and it moves into the renal pelvis, down into the ureters, to the bladder, and from the bladder to the urethra, and then it exits the body. So that is the normal filtration of the blood. Let's talk about some terminology that you should know. Anuria, no urine production, or by definition less than 100 mLs per day. Oliguria, 100 to 400 mLs per day. And polyuria, excessive production and excretion of urine. Terms that you should be familiar with. I put this in here because we talk about glomerular filtration rate, GFR. And we said that the blood moves into Bowman's capsule, into the glomerulus, and the glomerulus filters all the blood and makes a filtrate. And that filtrate is composed of toxins as well as fluids and electrolytes that are essential to the body. And so the glomerular filtration rate is the amount of filtrate that can be produced in 1 minute. And so there's a lot of factors that affect GFR, and we're going to talk about those. But we have these stages of renal disease here. And what is the glomerular filtration rate? What I want you to know is that a normal glomerular rate could be, it depends on the source that you're looking at, 125 to 100 is the maximum upper limit. What do I want you to know? When you are looking at lab results in a hospital, they will report GFR as greater than 60. So greater than 60 is considered normal. It'll be anywhere from 60 to 130. But what I want you to know is a GFR less than 15 indicates end-stage renal disease, and we are going to talk about that as we move through these slides. Let's talk about evaluating renal function. So, evaluating renal function is really important because changes in characteristics of the urine can indicate that there's damage or infection. It can indicate that we're excreting drugs or that the kidneys is compensating for some sort of a systemic homeostatic imbalance, like we talked about last week when we talked about heart failure and the kidney's ability to maintain perfusion and blood pressure. So let's look at urinalysis. So a urinalysis looks at the color, the clarity, and the odor of the urine. There is a microscopic evaluation that looks for cells. It looks for casts or crystals, any microorganisms that are in there. So that tells us, in general, how's the kidney functioning. Then we look at specific gravity and urine osmolality. So specific gravity is an indication of the kidney's ability to concentrate or dilute the urine. Osmolality, urine osmolality, measures the number of solutes or particles that are present in the urine. Urine osmolality is a more accurate measure of urine concentration than specific gravity. Let's differentiate between serum osmolality and urine osmolality. In serum osmolality, sodium is the major player. So it's the concentration of sodium in the blood. In urine osmolality, it is the concentration of urea. And you'll remember that urea is the end product of protein metabolism. So when the liver is processing protein for distribution to all the cells in the body, it produces ammonia as a byproduct of that protein metabolism. And that ammonia binds with other elements like hydrogen and oxygen and carbon, and that combination is called urea. And urea is excreted, is filtered by the glomerulus and excreted in the urine. And we call that concentration of the urea in the urine osmolality. So the relationship of urine and blood osmolality is monitored very closely when we're talking about the kidney's ability to function. How is the kidney excreting and or holding on to urea as well as sodium? So when renal function is normal, there's a direct relationship between urine osmolality and serum osmolality. So when one goes up, the other goes up. If there's renal perfusion is diminished, there's a problem, urine osmolality becomes more elevated than the blood, and the specific gravity is elevated. So that's kind of a weird relationship. I just want you to know that we monitor urine osmolality and serum osmolality as an indication of renal function. And we'll talk about cardiac output in a second. I want to talk about creatinine clearance. Creatinine, you'll remember, is a byproduct of muscle metabolism, and it's excreted in the urine, and it's a direct result of GFR. So creatinine is excreted in the urine at a constant rate. Urea is has an opportunity to be reabsorbed in the distal convoluted tubule. So urea can shift after it's filtered out from the glomerulus. Creatinine is filtered only in the glomerulus, and it's produced at a constant rate. So creatinine, the amount of creatinine in the blood, tells us a lot about urine function. Creatinine clearance is defined as the amount of blood cleared of creatinine in 1 minute. So a decrease in creatinine clearance would indicate that there is a decrease in the glomerular filtration rate. And so creatinine clearance is a urine test. It is typically, in the past, we would say it's done with a 24-hour urine collection. And you'll remember about the rules about a 24-hour urine collection is you have the patient void, and then from right after the patient has voided, that's when you begin the 24-hour count. However, more recent studies have shown that we don't need to wait a whole 24 hours. It is possible to have accurate results in a shorter collection time. So, intake and output. Certainly, the kidney maintains fluid balance. So we are going to want to take a look at intake and output because, as we saw earlier, some of those terms, the polyuria, anuria, and so we want to see where our patient sits. Let's look at some of the blood studies as we're evaluating renal function. BUN, blood urea nitrogen. Urea, as we know, is the end result of protein metabolism. It's filtered by the glomerulus and it is eliminated in the urine. Glomerular filtration rate and the urine concentrating capacity is reflected by the concentration of urea in the urine. Since urea is filtered by the glomerulus, BUN levels increase as GFR decreases. So think about that. Urea is filtered in the glomerulus, and as the GFR goes down, as the filtration rate goes down, BUN goes up. BUN is also affected by hydration. It can be affected by protein intake, catabolism, GI bleeding, drugs, chronic liver disease. So a lot of things affect BUN. So because of that, we cannot use BUN alone as a reliable indicator for GFR. But in combination with other things, that gives us an indication of kidney function. So serum creatinine, we talked about creatinine clearance, the amount of creatinine that the kidney is able to excrete in the urine. Now we're talking about a serum creatinine because creatinine is the end product of muscle metabolism. It's filtered by the glomerulus, but like I said before, it does not undergo any other reabsorption in the renal tubules. So as we increase serum creatinine, we know that there is a decrease in the glomerular filtration rate, and that is the hallmark of kidney injury, kidney disease. So increased creatinine indicates a decrease in GFR. Increased BUN is an indication of decreased GFR, which are the hallmark signs of kidney injury or kidney disease. A word about this BUN to creatinine ratio. So reabsorption of urea can increase or decrease in the renal tubules, and creatinine can be reabsorbed. It is reabsorbed at a constant rate, and that is at the glomerular site. So under normal circumstances, a BUN to creatinine ratio is 10 to 1 or 15 to 1. But as BUN levels rise very quickly, because BUN levels rise much more quickly, especially in acute kidney injury, we'll talk about that in a little bit, than do creatinine levels. So early on, a really high BUN, like a 20 to 1 ratio, could indicate chronic acute kidney injury. Electrolytes. Potassium is the major intracellular electrolyte in the body, and the body is very intolerant of any kind of a significant change in potassium levels, and changes could result in lethal dysrhythmias. The kidney has a major role in maintaining fluid volume and electrolyte composition of the body fluids in the body. So when the kidney is not functioning properly, there are imbalances that can occur, and they can affect the function of, potassium is really important for our neurological system, for our musculoskeletal system, cardiovascular system, GI system. So potassium is really a very important electrolyte, and that is one of the things that we are going to take a look at. Not only calcium when we're looking at kidney function, but some of the other electrolytes might be off, and we'll talk about those in a little bit, but the major player here that we're talking about in terms of electrolyte is the potassium. Well, and certainly ABGs are evaluated because patients with acute kidney injury and chronic kidney disease often have metabolic acidosis, which we're going to talk about why and how we treat it. But so we are monitoring ABGs as an indication of metabolic disturbances in the body because of the kidneys. The metabolic acidosis comes from the kidney's inability to excrete hydrogen and potassium. Because of the destruction of cells, there's a release of the intracellular potassium, increasing potassium. And there is an inability to reabsorb and to hold on to bicarbonate, so we don't have any buffering system. But we're going to talk about that in a little bit, but just know that monitoring the ABGs is very important. Now we're going to move on to acute kidney injury, but before we do, I want to have one more comment. We talked a little bit about urine output, but you know that urine output's a really important physiologic sign. It's influenced by lots of different things. It can be influenced by increase in losses, from sweating or excretions, decreased oral intake. But I want to remind you that you have to look at the big picture. Just because somebody has oliguria and an increase in BUN and creatinine doesn't mean they have renal failure. It could be something associated with water conservation because they have some sort of a volume deficiency. So you have to look at the big whole picture to determine what is really wrong with the patient. Okay, acute kidney injury, formerly called acute renal failure, but the recommended nomenclature today is acute kidney injury. And it's not ACI, it's AKI. I'm just looking at that, acute kidney injury at the top, so make that correction. And acute kidney injury is a clinical syndrome characterized by rapid loss of renal function with progressive accumulation of nitrogenous wastes. Okay, so the body has some sort of an insult, a nephrotoxic drug, some sort of a major kidney injury like poor perfusion, and we're going to talk about what causes it in a minute. But some of the characteristics that you need to know about acute kidney injury is that it is got a rapid onset, it has a rapid loss of function, it can come on in hours to days after the initial insult to the kidney, and it could be something very slight or it could be some significant injury. That's kind of why the change in the nomenclature, because acute renal failure indicates that it's complete failure as opposed to acute kidney injury, where we have injury and we have a change in function, so change in BUN and creatinine and GFR, but not complete failure. So it could be something minor or it could be something very significant, and it could result in azotemia, or the accumulation of nitrogenous wastes in the blood. What we do know about acute kidney injury is that we have to treat it very quickly, and we want to get it reversed. Whatever the problem was, if it's a nephrotoxic drug, let's get it out of there. If it's poor perfusion, let's get that kidney perfused again. So we want to treat it very aggressively and rapidly to reverse the problem. And so we said we watch BUN and creatinine, and I said that BUN is the first to increase in acute kidney injury. It rises very quickly, which is an indicator that GFR is down, and then creatinine follows it. And 2 years ago, I would have said to you, some of the problem with early diagnosis is that we really don't have any biomarkers that give us really early detection. We have to wait until GFR is down and the BUN and creatinine start to get to be elevated. But there is new tests that have been approved for use outside of the United States, and they are currently under review for use inside the United States. I'm going to rattle off some names. I won't test you on them because they're not approved for use in the United States, but they are looking at cytokines that indicate that there is inflammation going on in the kidney. They are looking, which is interleukin 18. They are looking at a molecule called kidney injury molecule, abbreviated KIM-1. They're looking at this neutrophil. They call it NGAL. I'm not going to give you all the technical names, but these have been really very effective. In Pittsburgh, Children's Hospital in Pittsburgh has been using it to help detect early kidney injury in children, and it's been really, really effective. So just know that there's some things on the horizon with respect to acute kidney injury. So when we talk about pathophysiology and the etiology of acute kidney injury, we talk about saying it comes in 3 ways that you can get acute kidney injury: a pre-renal cause, an intrarenal cause, and a post-renal cause. In a pre-renal cause, it's anything that affects the blood flow to the kidney. Anything that blocks the blood or decreases the amount of blood that gets to the kidney in order to be able to be filtered. It is the most common cause of acute kidney injury, and if you don't correct it, then it could result in an intrarenal problem and a more chronic problem down the road. Okay, so when we talk about what could be a pre-renal cause, we say that it could be hypovolemia, so that is not enough circulating blood. That would be something like hemorrhage or severe dehydration or cardiogenic shock, something like that. It could be relative hypovolemia. Then we talk about hypovolemia that's resulting from massive vasodilation or peripheral pooling, something, or shifts of fluid from the intravascular space to the interstitial space, like we have with sepsis and anaphylaxis. Or it could come from an occlusion, like an arterial occlusion, like a clot or trauma to the renal artery. And what happens? So when we don't have enough blood getting to the kidney, we have a decrease in blood flow. And decrease in blood flow results in a decrease in GFR. And we have, because we don't have enough blood flow then, we have tubule endothelial ischemia. So the renal tubules are having ischemia. And that's why we say that if you don't fix the pre-renal cause fast enough, then you're going to have an intrarenal cause, which is an actual damage to the nephron inside the kidney. And we'll talk about that in 1 second. So the decrease in blood flow causes a decrease in GFR, and that decrease in blood flow causes renal tubule ischemia, and that ischemia can result in tubular necrosis and death. So when we talk about a pre-renal cause, we're really talking about a problem related to tissue perfusion, the kidney not being perfused properly. So the kidney needs to be perfused properly, and we know from studying when we studied heart failure that if the kidney's not being perfused properly, there are things that it can do to increase perfusion, like kicking in for the renin-angiotensin system, increasing the sympathetic nervous system. But that's why we need to get this acute kidney injury, the pre-renal cause, fixed so that it doesn't cause acute tubular necrosis and an intrarenal problem. So that we say that the kidney needs to have the perfect perfusion, and we measure that perfusion with the mean arterial pressure. So that's the amount, the proper pressure that it takes to perfuse and oxygenate the kidney. There is inconsistency in the literature as to when we would be concerned about renal perfusion. And the literature kind of jumps from 60 to 70, 65 in there. And I'm okay with that, the 60 to 70, because I don't really think there's any line in the sand where you can say somebody might be fine at 65 and somebody else have problem at 68 or 70. So just know once perfusion starts getting 65, 70, 60, we are at risk for hypoperfusion of the kidney and at risk for acute tubular necrosis. Even though they don't agree on the map, what they do know is if we don't have the right map, it will result in the loss of renal perfusion, the loss of the kidney's autoregulatory capacity. It can't autoregulate, and it results in a decrease in GFR. And all sources would agree that urine production less than 30 mLs per hour for 2 or 3 consecutive hours is a problem to be investigated, if nothing else. Remember, when you have that decreased tissue perfusion, it can come from intravascular volume depletion, so not enough circulating volume as in hemorrhage, or it can come from a relative hypovolemia like vasodilation, neurogenic shock, sepsis, anaphylaxis, or it can come from an occlusion in the renal artery, or it can come from what they say translocation of fluids like we have in sepsis, or severe ascites. The fluids there is just in the wrong category or in the wrong space. Let's look at intrarenal causes caused by conditions that cause direct damage to renal tissues, impairing nephrons' function. This is the most common, or no, I shouldn't say the most common. The most common is poor perfusion. The most common form of intrarenal acute kidney injury is acute tubular necrosis. It is caused by prolonged ischemia or nephrotoxic agents like aminoglycosides, like contrast dye, contrast media. So acute tubular necrosis could also come from rhabdomyolysis or myoglobinemia from burns. So we said, an ischemic event for acute tubular necrosis is what we just described. We have hypovolemia. We don't have enough blood getting to the kidney. The kidney has a decrease in GFR and a decrease in oxygenation. We have endothelial necrosis. That endothelial necrosis causes damage to the nephrons, and the actual damage to the nephrons is what we call the intrarenal cause. So acute tubular necrosis, it's fairly common after major surgeries and with shock and sepsis after trauma. And so when we talk about the ischemic acute tubular necrosis, it's from prolonged hypoperfusion. And we need to recognize hypoperfusion very, very quickly. And we talked about how to recognize hypoperfusion last week when we talked about heart failure. And so when we have prompt recognition, we can begin to prevent and reverse any of the hypoperfusion to the kidney. We also have acute tubular necrosis from toxic agents. So when we have concentrations of high concentrations of nephrotoxic substances in the renal tubule, that leads to necrosis, and the necrotic cells slough off and they obstruct the tubules and they impair glomerular filtration. And we said contrast dye and aminoglycosides. We should be looking for the possibility of toxic tubular necrosis after aminoglycosides 7 to 10 days after the treatment was initiated. And with contrast dye, we see it in like maybe 48 hours with a peak onset of like 3 to 5 days. But the key to preventing nephrotoxicity with those contrast dyes, as you know, because you are a good nurse, you are going to be hydrating your patient prior to going to, for whatever event needs to have contrast dye. Of course, the number one cause of toxicity to the nephrons, the intrarenal cause, is the use of NSAIDs. Because NSAIDs interfere with prostaglandin, that's why they control pain. But in the kidney, prostaglandin is responsible for vasodilation and helping to maintain the kidney's glomerular filtration rate. And if it blocks that vasodilation, we don't have the right pressure gradient for the glomerular filtration to work properly, and it results in acute tubular necrosis. So I want to talk about the phases of this intrarenal acute tubular necrosis problem. I'm just going to mention them. I don't need you to memorize anything, but just know this, how the process goes. We have an initial onset. That's the initial insult, where the massive amounts of hypovolemia and ischemia, or we have too many NSAIDs, or we have aminoglycoside or dye contrast. That initial onset, we might not even know there's a problem. Then we see the oliguric, sometimes a non-oliguric phase, but we're going to say the oliguric phase, where we have a decrease in urine production. At this point, BUN and creatinine. BUN is way high, creatinine is rising, and the goal here is to support renal function until the cells can heal. As the cells start to heal, we gradually enter into this diuretic phase where urine production starts to increase. And that's a good thing. Urine production starts to increase, but lots of times what happens is the nephrons are kind of repairing themselves or recovering, and the collecting duct is not working properly, so it has an inability to concentrate the urine, and so we actually have a diuretic phase. So in that diuretic phase, in the beginning it might be low urine production, but it starts to increase all the way up to significant diuresis because we're making urine, we just can't concentrate it. So we're going to watch then hydration status, and we want to prevent electrolyte disturbances, being that's the goal of treatment. And then lastly is the recovery phase. It might take months to even a year for normal function to normal or near normal function to return. And then lastly, postrenal causes, the least common. This is where there is mechanical obstruction of urinary flow. Remember that one functioning kidney is plenty to filter our blood, so it would have to be, for a postrenal cause to be identified, it would have to be some sort of an obstruction that blocks both kidneys from working, from being able to excrete urine. So we might be talking about a neoplasm of some sort. So what happens is, let's say we have a neoplasm of some sort and urine flow is obstructed, so then it causes like a retrograde back pressure into the renal collecting area, and that pressure affects the glomerular filtration rate, and that prolonged pressure that's happening for a long period of time might actually cause structural changes inside the kidney, which damage the nephron, which ultimately result in acute kidney injury. Pre-renal acute kidney injury and decreased cardiac output. This is an important slide. I want you to say decreased cardiac output resulting in altered tissue perfusion of the kidney. Please write that on your paper. Pre-renal acute kidney injury and decreased cardiac output resulting in decreased tissue perfusion to the kidney because of absolute hypovolemia, hemorrhage, relative hypovolemia, sepsis, neurogenic shock, arterial occlusion. This is important because this is a major concept that runs through almost all of the lessons that we do this semester. So if you can't discuss this, I've already talked about it, then you need to come to me so that I can help you to understand that and see that, because you're at a severe disadvantage going into any test if you don't fully understand how these things relate. Oh, sorry. Here you go. Run through. I didn't. My notes. It's not. These slides aren't there. So okay, we already talked about these intrarenal causes. I want you to focus mostly on the acute tubular necrosis in there as being the intrarenal cause. Here are the 4 phases that we talked about. Postrenal causes mostly being, like I said, probably most likely neoplasm. Now we're ready to talk about chronic kidney disease. So when we talk about chronic kidney disease, formerly called chronic renal failure. So now we're talking about a kidney disease because it's a long spectrum. And it ends with end-stage renal disease, but it's progressive, it's irreversible, and sometimes it's a result of an acute kidney injury, and sometimes it's a result of long-standing disease. 1 in 9 people have some degree of chronic kidney disease. And your textbook defines chronic kidney disease as the presence of kidney damage or a decrease in GFR less than 60 for 3 months. It is a result of the leading cause of kidney disease, I should say, is diabetes and hypertension. We see it so often. That is just progressive. Diabetes and hypertension ends in chronic kidney disease. Prolonged ischemia for people with heart failure who have an inability to pump to meet the oxygen demands of the kidney, maybe from glomerulonephritis and also from lupus. And we'll talk about lupus in a couple weeks. Kidney damage. There it is. Glomerular filtration rate less than 60 for 3 months. Markers of damage would be BUN, creatinine, GFR. We talk about the urine tests, and which we talked about a little bit earlier. Any imaging that might be done, to indicate that there is kidney damage, like kidney ultrasound, and we're going to talk about those in a little bit. But it's progressive, it's irreversible, and it is defined as GFR less than 60 for 3 consecutive months. Diabetes, hypertension, prolonged ischemia. The stages. Diminished renal reserve. Stage 1. That means that you have some decrease in renal function, but you're not accumulating any nitrogenous waste in your blood yet. That means that in this stage, many times it's manifested as nocturia. They call it recumbent nocturia. So that means when you lay down at night, your kidney's perfused a little better than it used to be, but it has an inability. You lay down at night and your kidney is better perfused than when you're standing up running around all day. And the kidney has the nephron is damaged to some extent, but because the collecting duct has an inability to concentrate, so we have that recumbent nocturia or polyuria at night. And then we have renal insufficiency, which means that you actually need to seek medical attention here. Wastes are building up in your blood. You're not really responsive to diuretics like you used to be. And we start seeing some of the effects of a failing kidney, not working, doing what it's supposed to be. And then there is the final stage called end-stage renal disease, where we have an excessive accumulation of nitrogenous wastes in the blood. We have a condition called uremia, which we're going to talk about. This person may very well need dialysis. We say that a GFR less than 15 is end-stage renal disease, probably in need of dialysis. Okay. Let's talk about uremia. Because as the kidney fails, it has a profound effect on all the body systems. There's not one cell in the body that is not affected by uremia. So uremia is waste product accumulation, and these substances, how they affect the rest of the body. And uremia is increased levels of urea, creatinine, phenols, hormones, electrolyte disturbances. So all of these things result in clinical manifestations of the body systems. Sorry for that typo. All the problems come from an increase in that urea. So let me give you a definition. Uremia is defined as clinical signs and symptoms of renal failure. The signs and symptoms start very vague, and as the kidney continues to deteriorate, the signs and symptoms increase. It's often difficult to tell because the symptoms may mimic other things like fatigue and anorexia, itching. They're kind of non-specific and very vague. Now, I like this lady here because after you're done studying, if you go back and on the big screen, you'll be able to see it. If you look at all these things, it looks at every single system and it gives you a quick rundown of the problems with each system. And we're going to talk about all these things, and you should be able to have a general sense of all of the clinical manifestations based on what this lady looks like. Let's do system by system. So in the urinary system, we can say it starts as polyuria because of the collecting duct's inability to concentrate the urine. And it moves to oliguria, a decrease in urine production. And then it moves to anuria, which is a no production. Here I'm using less than 40 mLs per 24 hours. I've seen it in textbooks less than 100 per 24 hours, but basically very little urine production. And it says we are going to want to look at specific gravity to see how well the urine is being concentrated. And we do that with a clean catch, which is part of a regular urinalysis. So it measures the kidney's ability to concentrate. With kidney disease, we have a fixed specific gravity. That means it's not changing at all. Acute kidney injury, there's very precise hourly urines to be sure if fluid volume overload is developing or worsening. So when we have chronic kidney disease, these are things that are there and we try and manage them. It's with the acute kidney injury that we're trying to prevent anything from happening. So we are doing all the things we do in chronic kidney disease, we're just doing them more frequently and more vigilantly with acute kidney injury. I put this in here because sometimes I think that it's difficult to understand urine-specific gravity, and we talk about all of these things this semester. So we're going to talk about things that reduce specific gravity or make the urine more dilute. So diabetes insipidus, certain renal diseases, excess fluid intake, diabetes, and the raised specific gravity with the adrenal insufficiency that we're going to talk about, the heart failure that we talk about, and liver disease that we're going to talk about this semester. So this is just for your reference. Metabolic disturbances come from waste product accumulation. As GFR goes down, BUN and creatinine go up. Remember that BUN is affected by other things. Protein intake, fever, certain medications. And as we have increase in waste products, we have nausea, vomiting, lethargy, fatigue, headaches. Fluid and electrolyte disturbances, acid-base disturbances. This is an important slide. We talked about potassium a little bit earlier, saying the body is very intolerant of big shifts in potassium. And with acute, particularly, and chronic kidney disease, potassium levels are elevated. And it results, why are potassium levels elevated? Because the kidney can't excrete it. Because the body is in this catabolic state where we are catabolizing lean muscle mass. So when we have, or tissue damage, so we release intracellular potassium. When we remember that potassium is the major intracellular ion. So we release intracellular potassium and an inability to excrete it, and potassium levels are high. It can cause fatal dysrhythmias, especially when levels reach 7 or 8. And we have sodium. Sodium is kind of a funny little electrolyte in renal disease because it may be elevated, it might be high, or it might be low, or it could be normal. The kidney has an inability to excrete it. So the body's going to hold on to sodium. But the body's also holding on to water, which could lead to dilutional hyponatremia. So we're holding on to sodium, but we're holding on to more water, so it looks like our sodium is less than it is. So sodium can be tricky in renal disease, and it can kind of go anywhere. It could be high, low, or normal. But what we do know is that we do retain sodium, and that sodium retention leads to edema, hypertension, and heart failure. Then there's good old calcium and phosphorus. We have increases in phosphorus. Phosphorus and calcium always run opposite. So if calcium is high, phosphorus is low. If calcium is low, phosphorus is high. Phosphorus is high because calcium is low. And calcium is low because we don't have GI absorption of calcium. And we'll talk about that in a little bit. Phosphorus is really important because it buffers urea. I'm not even going to talk about that. So calcium and phosphorus run opposite of each other. Calcium is low because the kidney is responsible to make vitamin D and to activate vitamin D. And activated vitamin D is necessary for GI absorption of calcium. So we don't have GI absorption of calcium. So calcium is low and phosphorus is high. The kidney has an inability to excrete it. And we'll talk about that in a little bit when we're talking about the musculoskeletal system. There's magnesium. Magnesium is primarily excreted by the kidney. So magnesium levels are high. And magnesium levels being high result in the absence of reflexes, decreased mental status. They often result in cardiac dysrhythmias, hypotension, and respiratory failure. Because remember, magnesium, it's not true in kidney disease, but magnesium and calcium usually are like to rise together because they counterbalance each other. Where calcium is responsible for exciting and contraction, magnesium likes to relax things. And when those two are nicely in balance, we don't have tetany or things being flaccid. So that's why when we see the side effects of magnesium, absence of reflexes and everything kind of slow and dull, because that's what it does. Bicarbonate is not on here, but bicarbonate cannot be reabsorbed by the kidney, so we don't have bicarb, and that bicarb, not having bicarb is a buffer, so that's one of the other reasons we're having trouble with metabolic acidosis. And let's talk about metabolic acidosis. So we don't have bicarbonate. That is the primary buffer for acid. We can't excrete hydrogen, and we can't excrete potassium. All of those things are leading to metabolic acidosis. We talked about ABGs and looking for metabolic acidosis, and you did that with Dr. Roy. So if you need to review, you will need to review acid-base balance for this test. Defective carbohydrate metabolism is related to impaired glucose metabolism and cellular resistance. And that cellular resistance may contribute to metabolic acidosis. Well, how's that? Because the insulin resistance does not allow insulin to move does not allow glucose to move inside the cell. Normally, insulin opens the windows to the cell, and glucose runs inside the cell, and potassium follows. With renal disease, we have cellular resistance. That means that the windows are not going to be able to open. That means that glucose doesn't move in. That means that potassium doesn't move in, and the increased potassium contributes to metabolic acidosis. In addition to that, we have hyperinsulinemia, which means that there's not enough insulin, or there's not enough glucose inside the cell, so the body thinks that it needs more insulin. So it makes lots and lots of insulin, and the cells are still not having the amount of energy that they need, and further complicating things because they don't have the amount of sugar that they need. They're going to burn fatty acids, and the byproduct of fatty acids is ketones, which again also makes the metabolic acidosis worse. Now, I just talked about that cell resistance, hyperglycemia, and metabolic acidosis. That's really important concept because it doesn't just happen in renal disease. It happens in all kinds of conditions, sepsis and a lot of the different shock states. A lot of the really bad, for lack of a better word, I apologize for using such an elementary word, but all of the bad conditions, all of the severe diseases that we might see, and we have anytime we can have our fight or flight response or an excessive central nervous system stimulation, we have the chance for hyperinsulinemia and that hypermetabolic state that we talk about, which is that cell resistance hyperglycemia leading to metabolic acidosis. Okay, well, that hyperinsulinemia also stimulates the production of triglycerides, so that people with chronic kidney disease have a lot of coronary artery disease problems because they have high triglycerides. They also have a decrease in the breakdown of an enzyme that allows triglycerides to be elevated. Most patients with chronic kidney disease end up dying from a cardiac dysfunction. Okay, hematologic system. Your kidney's really an important player in our blood volume. You know, we talk about it regulates with the renin-angiotensin-aldosterone and ADH. You know, it's involved in perfusion pressure. But the kidney is constantly checking oxygen levels, oxygen saturation, and volume. And it produces erythropoietin, which helps adjust blood volume. So erythropoietin is necessary for red blood cell production, and it also helps to maintain a healthy endothelium because it's responsible for promoting what they call angiogenesis, or the development of new blood vessels. So when we have chronic kidney disease, we often have anemia. And the anemia is thought to come from the decrease in the erythropoietin, nutritional deficiencies that the person has. The decrease in the erythropoietin changes the lifespan of the RBC, so it dies sooner. It affects hemolysis, so the destruction of the red blood cell. When we have chronic kidney disease, we're also taking a lot of samples of blood all the time. And these people have some bleeding tendencies. And the bleeding tendencies come from a platelet dysfunction. The common cause of bleeding in uremia is they have a poor platelet aggregation. And it seems that the uremic molecules break down the clotting cascade, so it breaks down the body's ability to make a clot. And that's why GI bleeding and the risk for hemorrhage are so great for patients in this particular category. In addition, the patient is really at risk for infection. Patients with chronic kidney disease are immunocompromised because the kidney is part of the immune response. And when we have all this uremia, it affects leukocytes. So what we have is a decrease in T cell activity and impaired phagocytosis. And we're going to talk about all of that in a couple weeks. But so just for now, know that the patient with chronic kidney disease is immunocompromised. Please know that it is because of decrease in T cells, and it is because of a decrease in phagocytosis. So these people are really at risk for infection. Actually, infection is one of the major causes of mortality in this population. Moving on to the cardiovascular system. So, according to your textbook, MI, ischemic heart disease, peripheral artery disease, heart failure, and stroke are the leading causes of death for people with chronic kidney disease. So let's look at how it works. Okay, so let's look at hypertension. 70 to 80% of patients with acute kidney injury and chronic kidney disease have hypertension. It comes because we have an increase in sodium and water retention, and we have an overactivation of the sympathetic nervous system, and we have stimulation of the renin-angiotensin system. So that's chronic. That's happening all the time. And so when we have this long-standing hypertension, so in chronic kidney disease or acute kidney injury, we're going to see hypertension in about 80% of the patients because of the fluid volume overload. When fluid volume overload, like in chronic kidney disease, goes on and on and on and on forever and ever, and we have that long-standing hypertension, we have long-standing fluid volume overload, we've got anemia, we end up having left ventricular failure, left ventricular hypertrophy. for all the reasons that we talked about with heart failure. We have an increase in preload, so it's working really hard. We have hypertension, so the left ventricle is working really hard. We end up getting left ventricular hypertrophy, and that's the beginning of the heart failure. Remember, you don't have heart failure without eventually getting kidney failure, and you don't have kidney disease without getting heart failure. So, dysrhythmias. In both acute and chronic, we have hyperkalemia. We talked about the inability to excrete the potassium. So it leads to dysrhythmias. So when you have a patient with kidney injury, with chronic kidney disease, you want to make sure you have them on a cardiac monitor, because you want to see what's going on. If they're going to have a lethal arrhythmia, you want to make sure you've got a monitor on there to know it. So if somebody has mild hyperkalemia, something less than 6, we can treat it with dietary restrictions or diuretics, because they will deplete potassium. Or we might give them a potassium binding resin. But when we have severe hyperkalemia, which is resulting in EKG changes, of course you have your patient on the monitor, we would give them calcium gluconate, IV calcium gluconate, because to antagonize the effects of potassium on the heart. So to counteract the effects of potassium on the heart. So what does potassium do on the heart? Potassium excites the heart. So we give calcium gluconate to antagonize that, which means that we are going to raise the threshold of excitability. We're going to make it a lot harder for that heart to be excited, or for that heart to contract and have the irregularities in the beat. We might give IV insulin and dextrose, because if I give IV insulin along with dextrose, because I do not want to have a hypoglycemic event, I am going to move glucose inside the cell, and when I move glucose inside the cell, the potassium is going to move with it. And you're saying, wait a minute, I thought that these people had a hyperinsulinemia. And in this case, in most cases, we can manage the potassium levels, and in the chronic kidney disease, without having to, those levels are not that high. They're chronic, and if they are that high, they're on dialysis by that point, and we are managing those electrolytes. So in this case, with the really, really high levels, we're most often talking about acute kidney injury, where there is muscle catabolism, but not some insulin resistance, but not the hyperinsulinemia that we see in the chronic disease. And then we have pericarditis, or what they call uremic pericarditis, where we have an inflammation of the pericardial membrane because of all of the uric acid, all the uremia that is in there. It's not exactly sure why there is this uremic pericarditis, but like I said, they do believe it has to do with all the uremic toxins. And occasionally it can progress to a pericardial effusion. And, of course, the complication of pericardial effusion is cardiac tamponade. So and the pericardial effusion, you remember, is usually manifested by a pericardial friction rub, chest pain, maybe even a low-grade fever in there. Let's talk about the respiratory system. Kussmaul's respiration. Why? Of course, we have that. This person's got metabolic acidosis from multiple causes. So yes, they are breathing very, very quickly. They are trying to quick, shallow respirations. They are trying to blow off the CO2 to try to adjust and buffer that metabolic acidosis. Pulmonary edema. Of course, we have pulmonary edema secondary to fluid volume overload. Maybe even secondary to heart failure. And pulmonary edema, dyspnea, are a complication of acute kidney injury as well as end-stage renal disease. Dyspnea comes from the fluid volume overload and pulmonary edema, maybe even from the uremic pleuritis. Again, from all the uremic toxins in there, it makes an inflammation of the lining of the lung. And of course, this patient is at risk for pneumonia because they have impaired immune system. They're immunocompromised. As well, because they have a decrease in microphage, phagocytic activity, and also because they have fluid volume overload and maybe some fluid down in there, making it warm and dark and moist, and then the pneumonia develops. And like I said, every single body system is affected when we talk about this kidney disease, kidney injury. And the GI tract is also affected. We have lots of GI bleeds, and the GI bleeding comes from impaired platelet aggregation. But in addition to that, we have all these toxins that affect the GI tract. Urea is in the GI tract, right? And it's broken down into ammonia and carbon dioxide, and ammonia is an acid. And when we have all of this ammonia and this acid in the GI tract, it destroys the mucosa, and so irritates the mucosa, and it causes the capillaries to be very fragile in there because they have an acid on them, and that causes ulcerations, and those ulcerations, like I said, along with the poor platelet aggregation, causing clotting abnormalities, leading to GI bleeding. Lots of times it leads to pain. You can imagine ulcers are painful, and a decrease in appetite. These patients, because of the same thing, the toxins, develop often a stomatitis and ulcerations in their mouth. Many complain of a metallic taste in their mouth, and you see this uremic fetor, they call it. It's the smell of urine or ammonia on their breath that's very, very common. And also, you see, I did note there the decreased GI absorption of calcium, because you'll remember that the kidney is responsible to activate vitamin D, and without activated vitamin D, we cannot have GI absorption of calcium, which is one of the reasons why calcium is low. It's also being held down low because the phosphorus is high due to the kidney's inability to excrete it. So, more about calcium on the next slide. Okay. So, calcium is low because the kidney has the inability to get active vitamin D. And because of that, we have chronic kidney disease, mineral and bone disorder, CKD, MBD. It's a syndrome of skeletal changes. It's because there are alterations in calcium and phosphorus. It makes the bones weak and makes the person at risk for fracture. How's it work? Well, the kidney is responsible. The kidney is not able to excrete phosphorus, so phosphorus is high. Since phosphorus and calcium have an inverse relationship, calcium is going to be low. In addition to that, the kidney can't activate vitamin D, so we're not absorbing GI calcium. When we don't have calcium, when there is a drop in calcium, calcium is a super, super important electrolyte. It's so important because it has to do with everything. It affects the muscles, it affects neurologic system, cardiovascular system. It's very important. And because of that, it's got its own little gland for regulation. So the parathyroid gland regulates calcium and phosphorus levels. So when calcium levels drop, the parathyroid gland releases parathyroid hormone. And parathyroid hormone, what that does under normal circumstances, it goes to our long bones and it goes shopping in there for some calcium. Just, it's like a refrigerator, these long bones, and you open it up and you take out a little calcium. And for normal purposes, if you're low on calcium, it takes a little bit of stores out and puts your calcium right where it needs to be. But when you have prolonged decreases in calcium and parathyroid hormone is coursing through your blood, you are constantly taking out these stores of calcium out of your bones. So your bones become very, very weak. And when the bones become very weak, you are susceptible to fractures. So in addition to having weak bones, they're susceptible to fractures because you're not taking in any more dietary calcium to backfill those stores, and it's constantly coming out because we're constantly taking calcium out because calcium is low because phosphorus is high. I'm trying to look and see. I wanted to say that in addition, we have these calcium phosphorus crystals that form, and they make like a precipitate, and it goes to your brain and causes some encephalopathy. It affects their eyes, it affects the heart and lungs. A lot of that is some of that, it can affect blood vessels, further making cardiovascular disease an issue. It can affect skin. Okay, the neurologic system. Acute kidney injury and chronic kidney disease cause the accumulation of waste products and hydrogen ions because they're not being excreted, and they cause metabolic acidosis. And all of those things, the waste products, the increase in and the metabolic acidosis, and all the hydrogen that's in there, cause a demyelination of the nerve fibers, and they can cause a decrease in mental functioning. And you see, especially in end-stage disease and in a severe case of acute kidney injury, you see lethargy and a decreased ability to concentrate and irritability. It can even end with encephalopathy, confusion, and coma. We see it manifested in the periphery as muscle twitching and restless leg syndrome, peripheral neuropathy. And then the integumentary system, itching. Not often seen, but something they call a uremic frost, where it looks like, I've seen it over the years, but not in every single patient. It almost looks like there's baby powder on their skin, some sort of a talcum powder. It's a uremic frost because that's all the deposits of urea on the skin. It's kind of late finding. We don't see it like we used to because we have more aggressive treatments for end-stage renal disease. People are living a lot longer. We have better treatment than we used to. But in addition to that, all of the itchy skin that may result in infections secondary to crazy scratching, really. Crazy scratching. And I'm looking at my notes here to see if there's anything that I wanted to say. I'm back to the neurologic system, something that I forgot to say, which I should have said. in addition to all the toxins causing problems with confusion and demyelination of the nerves and restless leg syndrome and those things, you have to remember that there is fluid volume overload also. And that fluid volume overload can cause dilutional hyponatremia. Remember, we said that sodium could be low. And if sodium is low and we have hyponatremia and it's severe, that can cause cerebral edema and possibly an increase in intracranial pressure. You are going to have a whole lesson on ICP, and you did do it with Dr. Roy when you did fluids and electrolytes, but just know that that is a concern. Okay, back to the integumentary system. So we got this intense itching that the person may have, and I am concerned about bleeding as well as infection because there is poor platelet aggregation and there is the patient's immunocompromised because of the T cell dysfunction as well as the phagocytic dysfunction. There is protein wasting for these patients. So they're burning up a lot of protein. And because of that, their hair might be thin, their nails are going to be breaking. They have petechiae and ecchymosis because of the platelet dysfunction. So bruising is pretty common in these patients. Okay, let's diagnose stuff. How do we do? How do we diagnose what's going to tell us what's going on in the patient? We talked about the urinalysis before. It's going to help tell us about the different type of acute kidney injury that the person might have or an infection. So it is recommended that physicians' offices after 40 years old do a routine screening for chronic kidney disease. It's just a dipstick. They can dip it in there and they're looking for microalbuminemia. So patients spill protein in their urine when they have kidney disease. And so if we're looking for microalbuminemia, that's early indication that maybe the kidney is not doing as well as we thought, because something I don't think I said is that we don't start seeing any signs and symptoms of chronic disease until 80% of the nephrons are gone. Okay, so a routine urinalysis it will help us detect any white blood cells, any proteins, any casts, any glucose that's being spilled in there, because remember, when we have this chronic kidney disease and acute kidney injury, GFR is down. That means that there's a lot of things that aren't being reabsorbed back in through the tubules. So all kinds, the urine is, it could be too concentrated, it could with full of different types of solutes, so it's, all kinds of things are going on in there. It will also tell us about urine osmolality, sodium content, and specific gravity, which we talked about. We are going to be checking pH. We're checking for proteins. We're checking for ketones. We are checking for the trace microalbuminemia to indicate that's a very early sign of damage. Like I said, the urinalysis tells us proteinuria because they were spilling larger quantities because of an impaired nephron. We're going to look at a BMP, base metabolic profile, in which we will get the serum creatinine level. And values differ from lab to lab, but it's roughly 1.0. And critical levels is between 3 and 8, but the critical value of 3 is something that you must remember. Going to want to do a CBC, BUN, creatinine, GFR. Remember, BUN and creatinine be elevated, GFR will be falling. If we are talking about acute kidney injury, BUN is going to rise before creatinine. Fluid and electrolytes, or electrolytes, I should say. Potassium will be elevated. Potassium will be elevated. Phosphorus will be elevated. Magnesium will be elevated. Calcium will be low. And sodium could go either way. Hemoglobin hematocrit, because of the erythropoietin and the anemia, are going to be important. We are going to want to do a lipid profile. We are going to want to do ABGs because of the metabolic acidosis. Collaborative management. So treatment should focus on treating the underlying cause, and treatment should focus on fluid volume overload, nutritional imbalances because of the protein catabolism, electrolyte and acid base disturbances, and treating infections and preventing anemia. So let's worry about fluid volume overload first. So fluid volume overload, we have the stimulation of the sympathetic nervous system, stimulation of the renin-angiotensin-aldosterone system, and an inability to excrete, which cause fluid volume overload, and that fluid volume overload could lead to heart failure or pulmonary edema. So how do we treat fluid volume overload? Well, first we start with fluid restrictions. Strict I&O, especially with acute kidney disease. And so the fluid restriction amount that we often see is in acute kidney injury. The sum of all of the output, that means your urine output, anything out of an NG tube or a drain or anything like that, plus 1 liter. That's for acute kidney injury. The sum of yesterday's, 24 hours ago, the sum of yesterday's output plus 1 liter. In chronic kidney, and I've seen that is the newest information that I can find. That is what is said in your Morton and Fontaine book. In previous years, they were more restrictive, and they're trying to lighten the requirements because fluid restriction is very tough on people. So in some sources, I still see as low as 500 or 600 plus the day's output from the day before. But the most current that I can see, according to your Morton and Fontaine book, is one for acute kidney injury is 1 liter plus the sum of the day's output. In chronic kidney disease, they don't usually have to have a fluid restriction until maybe later on when they're on dialysis. And so when they are on dialysis, it is the previous day's urine plus 600. So the patients also need to limit their intake so that they don't want them to gain any more than 1 to 3 kilograms between dialysis sessions. So fluid restriction. Then diuretics is often used, especially in acute kidney injury, to promote fluid removal and to increase urine production, and it depends on the severity of your acute kidney injury. So the type of diuretic is determined after you consider the patient's symptoms and what their overload status is, their electrolyte status, and their acid base balance. With diuretics, the ultimate goal is to improve cardiopulmonary status. Loop diuretics are probably the most frequently used, I'll say. So furosemide or Lasix continue to be the most widely used, the loop diuretic, mostly Lasix. And when we're giving a diuretic, we are concerned about over diuresis, which is the most common problem. And of course, the last thing, which we'll talk about in a little bit, for fluid volume overload is the use of dialysis. So managing nutritional imbalances with acute kidney injury is a major concern, because when we have acute kidney injury, the person is in a hypermetabolic, hypercatabolic state. Or I should say, maybe they have a hypermetabolic, hypercatabolic response. And that's a result because patients experience skeletal muscle breakdown because protein synthesis is suppressed and the body is depleted of its energy stores, and urea production is high, and insulin resistance is so big. So they have because they have a lot of muscle catabolism. So to prevent muscle catabolism, those that are acutely ill, so this is talking about acute kidney injury here, we put them on enteral feedings. That's what's recommended, is these enteral feedings, so that they don't have all this muscle wasting. With chronic kidney disease, the current diet recommendations are designed to help the person eat as normal as possible, because we don't want them to be malnourished. So calorie protein malnutrition is a potential, and it's a serious problem because it comes from altered metabolism and anemia, anorexia, and nausea. So we try to limit the amount of protein, sodium, potassium, and phosphorus. So limit, because we don't want that protein calorie malnutrition for those that are with chronic kidney disease. And like I said, those with acute kidney disease are going to have enteral feedings to prevent muscle catabolism. So we like to restrict protein to 1 gram per kilogram, so to slow the progression of the disease, because uremia is coming from protein metabolism. So we can't have protein malnutrition, but we definitely want to restrict the amount. So proteins that we do eat with chronic kidney disease, they say need to have high biologic value. That means that they're good protein choices. So these are eggs, good meat, plant-based proteins, like soy and things like that. Then patients with hemodialysis do not typically have a protein dietary restriction. And patients with peritoneal dialysis actually get a bit higher amounts of protein to compensate for the loss during dialysis. So restrictions of all those things, it's important for you to know the foods that are high in sodium, potassium, phosphorus. So we're restricting sodium and potassium. Sodium is restricted to 2 to 4 grams per day. Where is sodium found? So we're restricting cured meat, pickled foods, canned soup and stews, things like that. Hot dogs, cold cuts, soy sauce. Salad dressings are high in sodium. And potassium is restricted, and it depends on how much, depends on how well your kidney is excreting. So you need to avoid salt substitute because they are high in potassium. Other things that are high in potassium now you should look these up. I'm going to give you a couple out of my head, but you should know dietary choices for advising your patients. So like apricots and avocados, bananas, oranges, raisins, carrots, potatoes, tomatoes. I think some beans are high in potassium. I think broccoli is high in potassium. I think I said prunes and raisins are high in potassium. Phosphorus restriction. The phosphorus restriction is tough because we do want to encourage calcium, but phosphorus is usually in things that have calcium. Other things, so dairy foods are high in phosphorus, and meat and dairy, and like I said, meat and dairy products, and lots of things that are high in protein contain phosphorus as well. So. Okay, managing electrolyte and acid-base disturbances. Hyperkalemia. Critical elevations greater than 6 in potassium can result in a lethal dysrhythmia. So you got to get your patient on a cardiac monitor, like I said. And then there are 3 phases to treating symptomatic hyperkalemia. We need to stabilize the cardiac tissue. And we stabilize the cardiac tissue, as I talked about before, with calcium gluconate. So it antagonizes the effects of potassium on the cardiac muscle. Or another way to say that is it lowers the threshold of excitability. Phase 1, stabilize cardiac tissue. Phase 2, shift the potassium back into the cell. We can shift the potassium back into the cell by giving sodium bicarbonate. We can shift the potassium back into the cell by giving insulin and glucose. Both will take extracellular potassium and move it to the intracellular space. And the last thing is to remove excess potassium from the body, and we can do that with furosemide or another loop diuretic, Bumex maybe. Or we can do a cation exchange agent like Etiology, where it exchanges sodium ions for potassium. Or we might do hemodialysis to get excess potassium from the body. A word about Etiology. We can give it orally or we can give it via enema. But you need to assess bowel function because you got to be very careful that there's not a paralytic ileus before you give that. Okay, treating sodium imbalances. We said that sodium can be high or can be low, and we just need to manage it and look at where it is. So we can give IVs that have sodium in it, or free water can be used. So an IV solution to correct a sodium imbalance depending on what that imbalance is. And then, of course, metabolic acidosis affects all normal cellular function. So we have the acidosis, as I've said before, because of the increased concentration of potassium, because we can't excrete it, because we have an inability to excrete the potassium, because we have an inability to excrete hydrogen. So we have all of this. So acidosis increases potassium concentration, and it induces a net shift of potassium from the intracellular to the intravascular compartment in exchange for hydrogen. So that's part of the acidosis. The injured kidneys can't remove potassium or hydrogen, and the bicarb can't be reabsorbed. So we have this metabolic acidosis. So what do we do to treat it? We treat it with IV fluids and careful infusion of bicarbonate, and we can treat it with dialysis. And then lastly, we have the electrolyte disturbances, because we have that calcium and phosphorus dysfunction, the bone mineral disorder. And so what are we going to do? We are going to limit phosphorus. We are going to administer phosphate binder like Foslo or Caltrate. They bind to phosphorus in the bowel, and then they're excreted in the stool. When we're giving those, we want to administer them with meals. We want to watch for constipation and maybe the need for a stool softener while they are getting those phosphate binders. So we're limiting phosphate, we're getting a phosphate binder, we want to supplement vitamin D, and we may even want to control the hyperparathyroidism, because remember that the calcium is low, so parathyroid hormone is making parathyroid gland is making parathyroid hormone, and so it's taking calcium out of the bone, but it's kind of a vicious circle. So we can give what they call a calcimimetic, so it mimics calcium so that the parathyroid gland thinks that calcium levels are better than they are, and it will allow calcium deposits to remain in the bone. And the drug that we give there is called Sensipar. And if we have hypocalcemia, we can give a prevent and treat infection. Well, we said that kidney disease affects monocyte action. It suppresses T cells, and it suppresses phagocytic activity, monocyte activity. So their person is at risk for infection. So they're immunocompromised. So anybody who has renal dysfunction has an increased chance of nosocomial infections. So strict hand washing and asepsis are critical for their care. Anemia is associated with chronic kidney disease, and it's treated with erythropoietin. You want to try and get a hematocrit between 33 and 38 and a hemoglobin 11 or 12. Supplementing with iron and folic acid is recommended. We don't really want the hemoglobin to be too high, because a hemoglobin above 12 has been linked to an increased risk of death related to serious thromboemboli and other cardiovascular events. So the goal is a hemoglobin between 11 and 12 and not over 12. Let's see. So erythropoietin can be administered IV or sub-Q, and it's done after dialysis. It takes a couple weeks for the erythropoietin to work, 2 to 3 weeks. And the expected outcome is to decrease the fatigue associated with anemia and increase exercise tolerance. And a side effect is the development of an iron deficiency because we need more iron, because we're giving them erythropoietin. So that's why the iron and folic acid supplements. And then treating hypertension is critical. Fluid volume overload done with diuretics or with ACE and ARBs to reverse the neurohormonal effects and some of the hypertension. So mostly ACE and ARBs, and you'll see other things used to control the hypertension as well. But these are the first lines of defense and the targeted drugs. What do we have to do? Daily weights, blood pressure. You're looking for signs and symptoms of fluid volume overload and hyperkalemia. Signs and symptoms of fluid volume overload include edema, include increased weight, include increased blood pressure, include pulmonary edema. Remember, we are talking about fluid volume overload here, and when we talk about fluid volume overload, that is called fluid status. And when we talk about fluid status, we talk about monitoring weight and blood pressure as the main indicators of fluid status. Last week, we talked about perfusion, tissue perfusion. And when we are looking at tissue perfusion, that's when we are looking at renal output, skin temperature, O2 sat, and level of confusion. So here we're talking about monitoring for fluid volume overload, and you are talking about fluid status. These statements that I'm making here are critical concepts to understand. We will test it 100 different ways this semester. The difference between tissue perfusion and fluid status. Fluid volume overload is fluid status. Strict dietary adherence to low phosphorus, low sodium, low protein. Medication, education, and motivating your patient just to manage themselves with this disease. There are 3 types of renal replacement therapy that we are going to talk about. Renal replacement therapy is really dialysis. Dialysis is a life maintaining therapy. It replaces renal function in acute kidney injury as well as end-stage renal disease. The 3 most common forms I have listed here: hemodialysis, continuous renal replacement therapy, and peritoneal dialysis. All 3 forms use the principles of diffusion and osmosis to remove wastes and excess fluid from the blood. Hemodialysis uses an external machine to act as an artificial kidney. We have to have access, and access comes in a couple different ways. Access comes through a dual lumen central catheter. These caths should never be used for any other purpose than hemodialysis. So let's talk about some of the rules. Don't inject IV fluids or medications into the catheter. After the catheters are done being used, they usually have heparin back in there, and the dialysis nurse will do that. You don't unclamp the catheters unless you're doing something for dialysis. We always maintain sterile technique when we're handling these vascular access devices, and we're always monitoring the site for any kind of signs and symptoms of infection. Okay, so that's one access device. And the other access device is an AV fistula. It usually goes in the arm, upper or lower. And a surgeon anastomoses an artery and a vein together and then creates a fistula or an artificial opening between them. So arterial blood flows into the vein, and it results in vasodilation of the vein, which makes puncturing it a lot easier. It takes about 1 to 3 months for the fistula to develop after the surgeon creates the fistula. So what to remember: never take a blood pressure or draw blood in the limb that's accessed. We listen for a bruit and palpate or feel a thrill, and you should do that every 8 hours. We don't have any tight clothing. You never put a restraint on that arm. I think that's about it. Nothing tight. Yes, feel the thrill. Listen to the bruit. And then the last type of access is a synthetic graft. If for some reason the patient can't use their own vessel, they use a synthetic man-made graft, and the graft is anastomosed between a vein and an artery, and it to make a little access pocket, and it takes about 2 to 3 weeks after the graft is put in order to use it. Same principles, feel the thrill, hear the bruit, don't take a blood pressure on that side, don't put restraints on there. those types of things. Let's think about some of the things that we should be teaching our patient who has these shunts. Washing their fistula site with antibacterial soap each day and always before dialysis is critical because infection is a huge concern. They get tiny little scabs from the puncture wounds. They should not be picking those scabs. We want to teach them about signs and symptoms of infection and anything that looks like a little abscess or a tiny little pimple that they should be reporting. We want to make sure that they rotate the actual insertion site from the dialysis. Let's see. No tight clothing, no jewelry on that arm. They shouldn't be sleeping with their head on that arm where their access site is. We don't use, again, they should be reminding people not to use blood pressure or blood draws on that particular arm. And I think that's about it. Okay, so let's talk a little bit about it. So what happens? So they created this fistula or a graft, or they have a vascular central access device, and so the blood comes out of the artery and it goes through this machine, which is an artificial kidney that circulates, that pulls out makes a filtrate just like the glomerulus would, and then it puts clean blood back in that's all filtered out of extra toxins, extra electrolytes, and extra fluids. And then they do that every couple days. So before somebody goes to dialysis, it is your job to get a set of signs and get a weight on that person. Complications of hemodialysis, something called disequilibrium syndrome, which results from, it comes sometimes because they need to slow down the dialysis, how fast the fluid is coming off. And so the person might have a headache or restless or mild confusion, seizures at the worst, but a headache and kind of out of it, just disequilibrium, as the name would indicate. Other complications would be hypovolemia and as a result hypotension, because probably the fluid was removed too quickly. So people who tend to have hypotension after dialysis, we would want to be careful about giving antihypertensives ahead of time within 4 to 6 hours. Also to mention about dialysis, you should be certain when you have a patient who's getting dialysis, you need to look and see which medications are filtered out during the dialysis and get a medication time change, so that you can give those medications after the dialysis, because giving a medicine right before dialysis that's going to be filtered out is pointless. So you have to consider that, and you can certainly look in your PDA to see which drugs are filtered, and or speak to the dialysis nurse, or I'm sure each unit would have information about that as well. The other thing that could be a complication is muscle cramps. Then the next thing we have is renal replacement therapy. Renal replacement therapy is actually just continuous dialysis. Dialysis is done on an intermittent basis. CRRT, continuous renal replacement therapy, is a machine that's acting like an artificial kidney, and it happens for an extended period of time. Who needs continuous renal replacement therapy? People with severe metabolic acidosis or severe hyperkalemia, uremia that's causing pericarditis or encephalopathy, or sodium levels that got super high or super low, people that have pulmonary edema. So these are the most acute problems associated with acute kidney injury. And treatment is terminated when the patient is hemodynamically stable. That means that they're showing signs of recovering renal function. So then we could stop the renal replacement therapy. And then the last thing we want to talk about is peritoneal dialysis. And peritoneal dialysis is just as effective as hemodialysis. It's an alternate method. It works with the same principles of diffusion and osmosis. What they do is they put a catheter in the peritoneum, surgically put it in, and it's done. Everything about peritoneal dialysis is done sterile. We're talking full gown masks, everything, because you have a catheter that opens from the outside and it is a direct portal of entry into the peritoneum of that person. So infection is huge. So how's it work? We are going to have a period of inflow. So some fluid goes in, stays in the peritoneum for X amount of time prescribed by the physician. And that's called, so we have the inflow, fluid goes in, the dwell, how long it's in there, and then by diffusion and osmosis, we are pulling out toxins and extra fluids. And then we have the period of outflow, and that is when we are draining the fluid back out of the peritoneum. Everything is done with sterile technique. I&O are critical. Wait, asepsis. You change the tubing as the protocol for your institution. And we are doing a daily site dressing change at the site of the inserted catheter. Make sure the fluid is clear. Make sure the amount of fluid that came out is at least the same, if not greater than what went in. So report any non-clear fluid, report any smell or signs of infection. A couple notes that I think are important for you to know about dialysis. If somebody has a cardiac, these are important things. You won't really be doing dialysis. A dialysis nurse will be doing it. You might do peritoneal dialysis on a rare occasion, but these are the things that you need to know. If somebody has a cardiac arrest and you are doing peritoneal dialysis, you need to drain the abdomen immediately to maximize the effectiveness of your compressions. Okay, so outflow becomes very important. We talked about making sure the amount of fluid that came out is what went in. Any signs and symptoms of fluid retention are abdominal distension or complaint of fullness or weight gain. Any blood-tinged fluid that comes out is going to be a concern. Right after they have the catheter inserted, maybe there would be some blood tinge, but after a little bit of time, there should be nothing. And you should report signs and symptoms of peritonitis being a low-grade fever, abdominal pain, and any cloudy fluid return. Oh, here it is, hemodialysis, access device. Okay. Renal replacement therapy. We talked about continuous renal replacement and peritoneal dialysis, inflow, dwell, outflow. We talked about all that. Thank you very much. I appreciate your listening. As always, if you have any questions, please email or come to see me. Thank you.